Hello, guys, and welcome to another episode of Cutting Edge Health. Today, we're going to talk to you about some of the newer things that are out there and how it can be impactful for your health. If we haven't met, I'm Dr. Orlando Landrum. I'm a physician that helps patients understand their options for different issues that they might be able to experience that are either physical, meaning dealing with their bones, muscles, joints, nerves, or things that are going on from a mental standpoint, whether it's depression, PTSD, anxiety, and what are some of the scientific ways that can be able to improve those conditions and know the options that exist out there besides traditional things like medications alone or surgery as the mainstays only. Today, we're actually talking about two different conferences that I went to and kind of giving you the latest updates and tips on how they may be able to help you and what's coming down the line that might be useful. Sometimes having that aspect and advantage of having knowledge of what's happening currently that may not be part of your experience or things that are going to happen that may be able to improve your overall health can be an element that provides hope that you otherwise may not receive. And so that's what this video will do for those of you who are watching it either currently or going forward in the future. By the way, this is a pretty interactive one. So if you're joining live, if you have questions or things that you want to add, by all means, jump in. So as you can kind of see from the initial slide that was up, I went to two different conferences. One is the American Association of Orthopedic Medicine, and the other is the Clinical TMS Society, which stands for Transcranial Magnetic Stimulation. So at each one of them, they had two different offerings. Orthopedic medicine is not the same as what you would think would be orthopedic surgery. It's completely different. Instead, it's actually an entity or group that is predominantly focused on how to be able to treat musculoskeletal, meaning bone, skeletal, joint, cartilage type issues by using traditionally healing type techniques that can promote improvements in health as well as healing that has scientific basis that gets you back to doing the things that you want to do. So what are some of those things? Those are going to be things like prolotherapy, things like PRP, platelet-rich plasma, stem cell type therapy that are utilized in order to be able to give benefit that you otherwise wouldn't have. So when we talk about how to be able to improve health, that entity or group has been doing it for years and also doing some missions and internationally to be able to help disadvantaged populations be able to receive interesting treatments that can provide value. So we're going to kind of go through and show you a few different things that I think might be interesting and useful and unique. And in doing so, hopefully it gives you some understanding about what are some of the things that are out there that might be able to help you learn something that you may not have known and what might be able to kind of give you some benefit. So some of these are going to be a little bit hodgepodge, but bear with me. So that orthopedic medicine group that I just mentioned, one of the things that they did is talk about just problems and issues that not everyone knows. And so I'm going to show a couple of different pictures that can hopefully be useful, that can be able to help sort of, if you would, elucidate or explain my point. So one of those pictures is the following. Perhaps. Okay. So this picture is a picture of a slide that shows this other theorem of where pain is referred from, which was quite new to me, to be honest with you. And we take a look at this, it doesn't really look like much, but you can see there's a stick figure drawing kind of in the upper left hand that shows someone's legs and feet and ankle. And on the right hand side, kind of this profile picture of a person with their head, arm, and shoulder. So what the heck is this? What this is explaining is a different way that pain can be referred. Normally, when you talk to your physician, whether they're a primary care doctor, whether they're a neurosurgeon, orthopedic surgeon, pain medicine specialist, those individuals, they'll show you a graph that looks like and is explaining something that's called a dermal tonal distribution of nerves. So what exactly does that mean? One second. What that means is if you were to take a look at the spine, right, and you take a look at where the areas of the nerves are, these nerves go out and they represent a traditional portion on the body. So like a certain area of the neck where that nerve comes out it would traditionally go down the area of the arm, feed all the way down into the arm and into potentially the thumb, right? That's a dermatomal distribution. And that's normally how we'll have patients fill out, hey, where is this pain? And then we'll see, does that pain seem to match where it is? And sometimes patients will say, no, that's not the way my pain is. So then we'll say, oh, well, maybe it's a cutaneous nerve. Maybe it's a nerve that kind of sits and actually goes in a different area. Okay. Well, I got a comment from Vicky saying that the blinds are shining light on your face and it looks like Indian face paint. Okay. Well, I can't do anything about that right now. It'd be a little bit bright. Otherwise, if I changed it, so you may just have to bear with me, and you're not missing much with the facial light that's there. Hopefully, my commentary can be able to equate and give you guys some value. So going back to what I was just explaining, is sometimes patients would say that sensation of pain doesn't match the chart, right? Where there are actually other different types of maps that most docs don't know about. And this society actually talks about the historical representation of this being out for easily 50, 70 plus years, where they've mapped things that are called sclerotomes, which we know about in medicine, but we don't really look at and utilize all that much. And that is where it's a bone pathology, and it represents a different way that it actually shows completely different than a dermatomal distribution. Whether there's a ligamentous issue, which this is actually, this picture that I just showed you is the Hackett's ligaments, which is developed by someone named Hackett, that looked at how these areas kind of match different ligaments that are present within the body, whether it's the iliolumbar ligament, a posterior sacroiliac ligament, and those areas give a different feeling, a different sensation than what you otherwise would think about. And it can explain why you might have pain that doesn't match the textbooks, right? And so I think it's a really useful thing to talk about with your docs, with your physicians, of saying, well, maybe it's not a dermatomal distribution as normal, but maybe it is actually representative of a different distribution that's present in the body that we otherwise wouldn't normally think about. Okay. So that's one of the different items that was interesting at this conference that really kind of promoted some unique things. Let's see what else at that conference was of interest, and I think really provided a lot of value. And so one of those things is the following, and that is this, which is going to look a little hodgepodge, but bear with me for a second. I'll explain it. And that is this. So injuries to the cranial cervical junction. And so what this picture is showing is it's showing the areas of the aspect of the skull where it sits in relationship to the first and second vertebral bodies, and how many times we're looking at particularly just the bone issue. But there's a lot of ligaments, tendons, nerves, and arteries that exist in that area. And when they're injured, they can cause things that we just wouldn't normally expect. And some of those things include sensations of vertigo, nystagmus, changes with the eyes, nauseousness, other things that we wouldn't historically suspect would be a mechanical issue. And instead, we think of it being a nervous system issue, or particularly a GI or stomach type issue. And looking at that cranial cervical junction can be pretty useful. Many people would think, well, maybe X-ray alone may be sufficient, and it can be useful, but it may not be the primary way of dealing with it. There's also thoughts about whether MRI might be useful because it can give you details that X-ray traditionally cannot. But what we found might be important is 3 different imaging modalities. Normally, when you get an MRI and you're in a recumbent position, meaning you're kind of laying flat, or you're sort of supine, if you would. Well, they actually talk about how that skeletal relationship is, particularly how your brain sits within the areas in and around the skull, and those first areas of C1 and C2. And by being in a seated or standing position, how it changes the context and construct of how the nerves sit in relationship to when you are in a supine position. And so that might be one thing to potentially do. 2 is to be able to look at ultrasound in that area, particularly with the aspect of mobility and dynamic motion, where when your neck turns and changes position, you can see how that relationship is muscularly and how it looks in relationship to how it would be with its being static. And 3 would be to do something like a DMX study, where you actually have an X-ray that takes an image of you traditionally in profile, but sometimes an anterior view. And particularly in motion, it looks in relationship to how those cervical spines look when you move. And do they stay in position, or do they move when you, so meaning, do they move in relationship to each other, which they should not, when you have this kind of bend or movement in a lateral position. And those things can signify cervical instability, which can cause problems, like I mentioned earlier, that are not just related to the areas of you having problems or issues with just pain or mechanical issues, but having dynamics that give you a problem that's different than that. So when we take a look at this, it's a really interesting conference that looked at how you can have different changes that you otherwise wouldn't necessarily expect. Let's see. This picture talks about some other unique things that were kind of revolutionary a little bit. So this picture and slide shows the areas of things that are called microglia that sit in and around nerves and astrocytes. And these are cells that sit in and around nerves, and they are purported to potentially change and influence how well nerves can be able to function when they're injured or have a problem. It may contribute to different things like PTSD, possibly. And so this picture off to the left-hand side shows different slices of the brain. It shows different components of how you may have blood flow that's showing, and that blood flow may be influenced by the areas of these astrocytes. Full disclosure, these various different images are not my own. They are provided by the American Association of Orthopedic Medicine during the conference. This particular mention was from a doc named Sean Mulvaney. The other 2 were from docs that you can be able to reference according to the site. At the end of the day, what we're saying is that maybe it's not just the nerve having the issue, but the cells that support the nerve that can cause us to have kind of this ongoing issue with having things like PTSD or other things along those lines that can cause us problems and issues. Okay. So at the end of the day, they talked about different treatments and how to be able to provide relief, particularly for things like cartilage loss, where you can have osteoarthritis and the degree of degradation that sometimes people will have with, for instance, knee pain. So in knee pain, you could say, oh, well, I've lost this much cartilage. Traditionally, many doctors will say bone on bone. And when they say bone on bone, most of the time, the lay public may not necessarily have an idea about what are some of the alternatives you could actually be able to do besides just either take meds, cortisone injection, or surgery. Let me pause for a second. Actually, I have some questions coming in. So one question was, so neck ligaments may be causing pain instead of bone. Yes. They may be causing issues instead of it just being bone or it being a nerve compression. And so that's one of the things that was really interesting and unique about this particular conference. And one of the things that they actually put forth is there's documentation that there may be ways to improve that ligamentous structure that doesn't have to be reliant upon us dealing with trying to say, oh, well, you have a nerve compressed, or, oh, you have a bony issue, and so we have to deal with this because you have arthritis. There may be pain that's generated and mediated, if you would, by ligamentous laxity or ligamentous injury. So going back to what I was talking about, the areas of the nerve that have kind of like constriction and other things that are in place, that there may be ways to target some cells that can be able to improve not just our physical health, but also our mental health, which I think is a pretty decent segue into kind of the aspect of the second conference I went and attended. And the second conference is a conference that's called the Clinical TMS Society, which is a really interesting society. So those of you who have watched our channel, you've heard about transcranial magnetic stimulation, and you know that it is a non-invasive therapy that can be able to help you deal with aspects of depression, and particularly treatment-resistant depression. So what does that mean? Treatment-resistant depression is depression that is is centered and focused on depression that has been attempted to be treated with either traditional cognitive behavioral therapy or medications, and it hasn't responded. And instead, it's depression that is tough, it's difficult to manage, and there are other ways that you need to be able to treat it. In this case, using magnetic stimulation to try to be able to improve both the way you have increased levels of neurotransmitters, but also the way the brain talks to itself. And it was really an interesting conference that talked about the connectome, or how that brain talks and how the different brain, or if you would, kind of pathways can be strengthened by using different treatments, including TMS. So I'm going to show you a few different pictures of some of the TMS machines that are out there that are pretty unique and interesting. So one of those is the following. As we kind of pull up this picture, it looks like so. Let's see. Yeah. And this is the Apollo TMS, which shows a different alternative machine that uses a similar type energy. It's unique in that it has a different type of efficacy that you might not normally expect, meaning it has probably one of the quietest kind of like taps that exists. And it's of German design, and it has a number of different unique pieces that add to what it can be able to do compared to others. One of the others is the following. We're kind of take a quick look and show you this. Wait, sorry. It's trying to jump all around on me. There we go. And that is Brain Sway, which is a full-blown helmet that uses a different type of technology that the energy and how it's transmitted is of a different coil than what you'd have. And so kind of explaining it, one of the things that Brain Sway does is not just treat depression, and many of the machines can be able to do this, but they lean into being able to help people with other types of things like OCD, obsessive compulsive disorder, anxiety mixed with depression collectively together. And they also have talked about having different protocols that may be able to be useful for helping people quit smoking or stop things like food cravings or utilization of alcohol, which is some pretty interesting things. Okay. Also at that society, they had a number of different papers that were out there. And so this particular paper, although it kind of looks pretty simple and there's no big deal, it's in black and white, and why should we care anything about this, was a paper that was actually pretty darn interesting and revolutionary. And the reason why is because it dealt with one of the most kind of prolific, super followed and mediated like revolutionary thing in the last year or so in TMS. And that is something that's called the SAINT trial. So the SAINT trial was a trial that was developed by Stanford that looked at, instead of us doing a 36 session or 6-week session on average of TMS, compressing it down to 1 week. We've talked about this in some other videos and been able to kind of explain to you what was the dynamic for that. At the end of the day, this particular paper looked at not just using TMS in a compressed fashion, but to use it in conjunction with ketamine, particularly pain type levels of ketamine dosages, to see if you can get a better effect for depression in this particular case. As a matter of fact, the patients that they looked at had treatment-resistant depression, as mentioned before. And what they found is they got a heck of a result, a really improved result from just TMS, particularly in this case, the SAINT type dynamic, which is called accelerated TMS. When they use it in conjunction with ketamine, they got a better response than what they thought otherwise. So there's some thoughts about whether those two things may act synergistically to get a better result. Synergistically being, for those of you who may not follow our channel, if additive is 1 + 1 = 2, that instead 1 + 1 = 5. So you get a better result collectively together than what you otherwise would. So another interesting paper that kind of really looked and revolutionized where the research and science is kind of going. So one of the other things that was pretty interesting was the following, is that this paper looked at, and you may not be able to see it in depth and detail, but can there be things within your bloodstream that can tell you how well you might do for TMS and whether it's going to give you the response that you otherwise might not know? And so this looks at a specific molecule that's called kynurenine, which is a byproduct or breakdown product that looks at different inflammatory statuses. For those of you who are my patients, we actually do this in a study that we look at. That's a type of testing that we look at. And when that is present, what they have seen is that there's an increase in inflammation. And that increase in inflammation can be more likely to, as it's stated here, TMS with an increased serum BDNF levels, which is a different type of molecule, and decreased inflammatory markers in patients with depression compared to healthy controls. And kynurenine can be something that can help us identify how do we treat this and who's going to be a better responder than not. So pretty interesting, cool things that we just really wouldn't have normally thought about. But now can we say, hey, before you even start this treatment, is there a way for us to be able to kind of get some clarity about whether this might benefit you or not? Okay, moving on. Let's see, what were some of the other things that were pretty interesting at this? Actually, so unfortunately, I don't have a picture of this, but there was a really incredibly interesting paper that looked at TMS and how it can be able to benefit pain. For those of you who have followed our channel, we've talked about this before, but there was a really in-depth discussion by this one doc who looked at patient that had a previous failed back surgery. And so what did failed back surgery mean? So they had surgery with fusion rods and screws, and they didn't have improvement in pain as much as what we hoped or expected. And the interesting dynamic is that this psychiatrist had previously trained in neurosurgery prior to becoming a psychiatrist, and so knew a number of different neurosurgeons, and they felt comfortable having a discussion with him about how he might be able to intervene. And he used TMS with a certain type of parameter and protocol that got that patient greater than 70 to 80% relief that was sustainable. And I felt like hearing that conversation that was actually overlaid by one of the founders of TMS and pain, which is an anesthesiologist and pain doctor, Dr. Leung, who's out of UCSD, University of California, San Diego, and helps treat and deal with a number of our veterans, gave a phenomenal 2-hour-long talk that discussed how to be able to treat pain and where the different components of the cortical structures go to the midbrain. So what I mean when I say that is, so we have white and gray matter. We have areas that come into the areas of our cerebellum and cerebrum, and then they go to the midbrain structures like thalamus. And how can we be able to utilize that differently depending on the type of pain? And so what do I mean by that? So there are pain that are centrally mediated, meaning we have kind of this sensitization or this connection that's in deeper structures of the brain. And it's not, let me be clear for those of you who are watching this, it's not that the pain is all in your head. That's not what I'm saying at all. Rather, that those nerves propagate and make the pain worse than what we otherwise would expect, and actually make it more difficult to treat than a peripheral pain. So things like central post-stroke, where you have a stroke and you have pain because that stroke has affected a specific neuronal pathway that's present in the brain. There may be ways to be able to treat that with a certain type of TMS protocol versus back and leg pain that can be able to treat it in a different kind of way. A number of patients have asked me offline, is insurance normally covering pain treatments utilized by TMS? At this time, it's not, but it's one of the missions to be able to say, how can we be able to do different research that can show the validity and validness of how well it's been able to improve this. And it's actually been out there for quite some time, dating back to the early 2000s, of different treatment protocols that have been in place. And they're becoming more and more refined in how to be able to improve overall pain by using a non-invasive technology that is not based on a medicinal therapy at all. So meaning you don't need to have a needle, you don't need to have an incision, you don't need to have a medication that can be able to provide pain relief that can be sustainable and significant. Not like, well, you're an 8 and we take you down to a 6, but you're an 8 and we take you down to a 2. And they've been done across the gamut in different types of pain scenarios, whether it's been sciatica or whether it's been following a surgery or whether it's because of complex regional pain syndrome or post-amputation and phantom limb. It's very interesting and unique things that are going on. For those of you who are keeping up, I know I kind of jumped from one conference to another, so bear with me for a second because I want to go back to that American Association of Orthopedic Medicine. One of the really interesting things is how regenerative medicine is now really starting to get more traction and understanding and what's in place. Let me kind of pause my interests and kind of dynamic for just one quick second and wrap that up and then answer some of the questions that I see that are coming through. And thank you for those of you who are joining live. By the way, if you join at a later date, send us in questions and comments and we'll see what we can do about answering those comments offline. So quick little kind of summary and kind of tie it together. They've looked at, and for instance, knee, right, where you have a problem or issue and you have a loss of kind of cartilage. So if you're to kind of take a look at these two different knees, the one from your vantage point, if you're to take a look and you say on the left might be a normal knee, on the right where you see kind of those pink areas which represent the cartilage loss, or you may have a grade 0 versus like maybe a grade 1 or 2 where you have meniscus tears and other things that are in place. Those type of knee issues may be able to be treated by PRP alone, right? And you can be able to get a response. But as we get to something that's called grade 3 or grade 4, one of our videos talks about that. So if you want to understand that rating scale better, which historically, most of the time, docs, physicians, surgeons don't explain, which is kind of key in terms of understanding how bad your knees are. It's something that's called the KL grading system. Kellergan-Lewis grading system. When someone says you're on bone, so really that question should be is this a grade 4 or is it a grade 3? And it matters, but be that as it may, what we've seen is that grade 3 and grade 4 is traditionally going to be responsive to, at times, intra-articular stem cell therapy. Not for everybody, but for many people, it may be able to give a response. But many times it's not just intra-articular, but that you may need something that's called a subchondroplasty. And we've talked about that in videos too. So an intra-articular injection is going to look like you basically are going to come in and you place a needle into the area of the joint. While subchondroplasty is going to be where you actually place it into the bone with the intent that those cells then propagate down to the cartilage, as well as placing an intra-articular joint at the same time. So those two kind of have the advantage that the cells kind of meet in the middle and help improve those areas from where they were at baseline. So they actually talked about what does it look like and what's the best indications for what might work in the shoulder, what might work in the knee, what might work in the back, what might work in the neck, what might work in the ankle, what might work in the elbow. Some really interesting nuanced designs of that entity and how they can be able to provide value to people. As an aside, for those of you who are not watching in an area that may be served by our clinic, or you want to see other doctors, if you go to AAOM, specifically the American Academy of Orthopedic Medicine, they have a number of docs that are listed within the compendium of who's an actual member. And by seeking out some of those members, you may be able to get some of these same type of therapies potentially. In addition, the same thing is also present for the Clinical TMS Society, where they have a number of different physicians and healthcare groups that provide traditional TMS and other therapies that may be useful for people that have depression, have OCD, PTSD, and can be able to provide relief. Really interesting conferences across the board. Okay, so trying to sum this up, let's take a look at some questions that are out there. So one of the questions is, high inflammation might decrease TMS results. So it's not so much that TMS itself may be mitigated by that high inflammation. It's more so if you start off with an inflammatory level, could that potentially change what our outcome is? And what I would probably go with is maybe we might be able to improve the inflammatory status and get us an even better outcome. And maybe those are some things that we need to do. All right. So there's another question is what are some of the treatments for pain from ligaments? Well, we've talked about that before. So ligaments are not just uncharacterized entities that just are kind of out there and we don't do anything with them. So prolotherapy historically has been the treatment of ligaments, where you inject that ligament with kind of a substance that can make that ligament get stronger over time. Originally, it was the utilization of dextrose, in which those what many prolotherapists use currently. But there are other things you can inject that ligament with, including orthobiologics. So using our fancy terminology for that, those are going to be things like PRP or stem cells that you can inject into the ligament ligament to see if you can get a response and a strengthening. It was really interesting in hearing conversations from people who've been practicing not just 20 years, but sometimes 40, 50 years. And they talked about the iliolumbar ligament, which is a ligament that exists in the following area and region. If we're to take a look at a spine model and we're kind of look in relationship to the aspect of the sacrum, there's a ligament that kind of exists in the area where this pen/pencil is, that is small, not really seen, not noticed under MRI, but by targeting that ligament, it takes care of a fair amount of back pain, and it's not improved by chiropractic manipulation, from epidural steroid injections, from facet joint injections, or anything along those lines. You specifically have to know where it is, either through palpation or ultrasonographic evaluation, or injecting with contrast under fluoroscopy and saying, let's get after this ligament so we can improve pain, because that ligamented structure adds a fair amount of support to the skeletal structure. And when it has weakened, a weakness or laxity, it can cause some pain. So those things are pretty darn interesting in terms of like conferences that can be able to provide value to patients. If you have interest, please check them out as a layperson or as a medical provider, and maybe it can be helpful for yourself or someone that you care about. Thank you so much, as always, for your time and for tuning in. If you feel like this video is of value, please like it. If you feel like it might be useful for someone else, please share it. And if you're interested in learning more about different options that are out there for knowing how to be able to deal with your pain, whether it's physical or whether it's mental, and how to be able to punch pain in the face and getting back to leading the life that you deserve, then hit the subscribe button and come check us out at another time. Thank you so much and have a great day.